Well, the two advances that have excited me over the past year, the first one was the FDA approval of pembrolizumab, which is a PD-1 inhibitor from Merck. And this was a tumor-agnostic FDA approval, and this was really the first time that they had done this in patients with MSI high tumors or those with mismatch repair deficient tumors. And this was across different cancers, which was rather unique and really goes to show that one could potentially use molecular findings from patients to identify drugs that could work for them rather than base it on the geographical location of the actual cancer. The second advance was the recent publication in the New England Journal of Medicine of the TRK inhibitor larotrectinib. The first author was Alex Drillin from Memorial Sloan Kettering. This was a study that was led by the investigators from Memorial Sloan Kettering and also MD Anderson. And what they essentially showed was that you could actually administer this orally given drug to patients with TRK fusions, regardless, again, of their tumor type. And although this is found in about 1% of patients across different solid tumors, there was a response rate of approximately 75%. And these were durable responses in all of these patients. And it was a treatment that was also very well tolerated. So again, another tumor-agnostic type of treatment that goes across different cancers regardless of the geographical location and really based on the molecular findings of a patient's tumor. Well, in the short term, it's really to try and uncover the genetic abnormalities that one can see in patients' tumors through next-generation sequencing, and to actually try and widen their therapeutic options by tailoring different clinical trials or standard of care therapies to their particular molecular aberrations in their cancers. In the long run, we hope to learn from these aberrations and from the scientific discoveries in the underlying biology of these cancers to try and discover and develop better drugs that are tailored for these particular molecular aberrations. Well, I think we need greater research into this area in terms of trying to understand the origins of intratumor heterogeneity and what actually drives the heterogeneity. We need to try and differentiate between the founding ubiquitous mutations that are found throughout the cancer, which are the true drivers of cancer, versus the heterogeneous events that may not actually be driving the cancer at all. And that will be a big challenge, but by understanding these true drivers, one can actually then design strategies in combination therapies to rationally target these driver mutations. In terms of clonal evolution, the use of fresh contemporary biopsies will be extremely helpful to get a real-time view on the patient's genetic and molecular makeup of the cancer so that one can actually target that rationally with a treatment. Secondly, if patients are not easily biopsiable or safely biopsiable, then using circulating tumor DNA from plasma may also be extremely helpful as well. Well, in our department at MD Anderson, all of our patients who are suitable for a clinical trial will essentially get a next-generation sequencing testing or other screening tests for potential therapies that might match and are tailored towards the actual molecular makeup of their cancer. These results are then reviewed by our genomics, precision oncology decision support team, who actually then go through the current literature and also genomic databases to try and determine which of these aberrations, and there could be many, are actually true drivers versus which ones are actually passengers. We'll then convene a tumor board where we discuss the patient's oncology history and also their molecular makeup to try and determine which clinical trial would suit that patient best. Well, there's plenty of research that's currently ongoing in academic centers, and we really need to push that out now to community practices in terms of educating and also engaging not just healthcare professionals, but also patients and their families. And we really need to try and ensure that all patients have access to these different tests and also especially access to these modern treatments as well.